Dr. Rajesh Sahay will be speaking on examination of retina and finding the clue to diminished vision.
Okay, fine. Good afternoon, everyone. It feels very much into our own place and everybody familiar to me. And I feel very much at home, not nervous at all presenting this paper. So this presentation. So let me, sir has given us a very vague idea that what he exactly wants to talk about. So I finally decided I shall talk about all those patients who were referred to me of late. So these were the patients whom I'll be discussing. This is a case-based presentation where all these patients were referred to us for some opinion. And we did a detailed history and a careful examination and somehow could find the diagnosis. And this enabled us to decode vision defect and explain what was unexplained. So my first case is a 38-year-old lady, a housewife. She had a history of sudden painless loss of vision in left eye last month, which recovered in 1 week with some oral medication and drops. Past history of similar vision loss in right eye followed by spontaneous recovery in few days, and she was diabetic of 10 years duration. And on examination, her acuity was 6.6 in both eyes, color vision was normal, blood pressure was 120/70, but this HbA1c was not very good. Bad diabetes control, her CBCSR again was normal. This was her fundus photograph. I could not see any abnormality in the color photo or the red free. Did an OCT. So in the OCT, I found there is some SRF in the right eye, but that does not explain her vision loss, that significant vision loss that she was complaining of. The left eye absolutely was normal. So the probability of the vision loss in past was either retinal migraine due to spasm of retinal artery or amaurosis fugax, as we expect in such cases. Of course, I could rule out optic neuritis and migraine because there was no history of any pain and the duration of vision loss was not very prolonged. And CSR, of course, I ruled out because of such less fluid and does not recover so fast, quite unlikely to be CSR. So sent this patient for MRI or MRA, what was available there, and that revealed atherosclerotic changes in the, in the common carotid artery. And there was, you can see those red arrows pointing to the thrombus seen in the internal carotid artery. So the diagnosis was easy then. It was TIA or transient monocular vision loss. It was quite common in diabetics and hypertensives. A kind of emergency though, manifold, because there is manifold increase in the incidence of stroke in such patients. So our role is to guide these patients and refer to a neuro or a cardiac physician for care. My second case is a 60-year-old male who complained of defective vision in both eyes. Of course, the left eye was much more affected than the right eye. He has had a cataract surgery in left eye. Was very unhappy following cataract surgery. And he basically complained that his vision deteriorated further after the cataract surgery. So what could be thought of, having poor vision in this patient? This could be amblyopic in that eye. IOL related complications could be there, could be media opacities or some retinal or macular abnormalities, or optic nerve diseases could be the possibilities of poor vision following cataract surgery. So this is a fundus photograph. If you could see that the right eye photograph is not very clear, means some media opacity was there, but the complaint was mainly in the left eye. The media is very clear, and retina looks, the retina looks myopic. Vision was 636 in the right eye. This is corrected vision, 636 in the right eye. Left eye was 160, not improving by correction. And of course, PCL was there, but the refractive error was 12.5 in the unoperated eye, and in the operated it was 8.5. But despite 8.5, the vision wasn't improving. So we went ahead and did there's a detailed summary of the examination. And we found out this. This is, then it was obvious after the OCT that this is a case of macular schisis. So macular schisis is also known as myopic traction maculopathy. And of course, prior to OCT, it was very difficult to diagnose. And this results because of rigid ILM, anti-retraction, and progression of posterior staphylomas. and it could be in any layer. The schisis cavities could be in any layer of the retina, and it usually stays stable for many years until it develops macular holes or foveal detachments. Surgical intervention is indicated in progressive vision loss and worsening OCT findings, and we have options of PPV, ILM peeling, and macular buccal in such cases. My case 3 is 40-year-old housewife, obese, hypertensive, hypothyroid, on medication for various disorders, used to taking pills for pain relief occasionally. So why I emphasize all these things? But because we have to talk to the patient and extract the maximum information that sir has been pointing out in his talk earlier. And she complained of defective vision in left eye since 15 days. The fundus photo shows some, some gray, yellow, pale areas in both the eyes, but vision loss was mainly in the left because of the central involvement. So these are serous detachments. So probable diagnosis again was chorioretinitis, weak age, since no flares or cells were seen, no signs of inflammation, so we could rule out that. Could be CNV or atypical CSR. We did an OCT. We definitely found out some fluid collection under the retina in both the eyes. We did an angio, and it had multiple pinhead hyperfluorescence increasing and pooling in late phases. So definitely it clinches the diagnosis of atypical CSR, and this was because of the chronic use of steroids. She was using Medrol, which was found in her drug box. And this atypical CSR, okay, fine. So let's talk about 2 lines about atypical CSR. This is usually because of increased cortisol levels in the body because of hormonal disorders. And epleneron or subthreshold laser or micropulse laser could be useful in such cases. And this is the 4th case. This will be my last case. This is a 35-year-old male. You can see this fundus. Look at the fundus photograph. Defective night vision. This case was referred to us. Visual acuity 6/6 both eye, color vision normal, no systemic history, family history, sibling having similar night vision problems. Treated with vitamin supplements. The OCT probably you will not be able to make out much difference in the OCT from a normal in this particular case. But have a look. This is the fundus photograph when we tried to take the periphery. So this was missed by the initial the physician. And I'll show you the comparison of the OCT. This is the OCT of my patient, and this is the normal OCT, and this is advanced RP OCT. So in RP, the OCT changes are much in the outer side of the outer layers of the retina. So it is quite thin in the in my patient as well. So this was a case of retinitis pigmentosa, which was missed by the primary physician, and we all know that it's a heterogeneous group of inherited disorders. Most frequently known cause. Let's not talk about all this. The one thing interesting which I read recently is the Luxturna is a drug which has been tried for RP65, which is a Leber's variant, and it is basically a genetic treatment. And Argus 2 is an implant which is approved for no PL patients. So my time is up. Thank you very much.